the International Working Group of CLL has developed some really great guidelines or criteria for requiring CLL-directed treatment that we follow at Dana-Farber, and I think really are the gold standard in understanding when to treat someone for their CLL. Obviously, there are atypical cases that come in and out that may not fall within that criteria to treatment. But for the most part, we do follow that when deciding when to treat a patient. I think most commonly for my CLL patients, we treat them because they have developed progressive bone marrow failure due to a large involvement of CLL in the bone marrow. So what that will often look like is as the patient's absolute lymphocyte count is rising, we'll start seeing that their red cells and their platelets are trending down. And that's because the bone marrow cannot perform normal hematopoiesis anymore because the CLL is in such a large volume in the bone marrow space. So we see the red cells start ticking down, the platelets start ticking down. And usually once the red cells are trending, the hemoglobin's trending below 10 and the platelets are steadily trending down, that's when we'll start initiating the conversations about CLL treatment. Fortunately, because CLL is a slower growing lymphoma, if you initiate that treatment discussion and the patient's like, I'm going on a cruise in 2 weeks, this is really not the optimal time to start treatment. We often will have some flexibility to say, okay, go on your cruise and then we'll come back to this. Sometimes there are patients, obviously, that have a little bit more aggressive disease, and when they can surprise you sometimes in clinic, and you're like, we should have started treatment yesterday. But for the most part, we can sort of predict when someone will start needing treatment, and it's a discussion over several visits. It's not they come in one day and we say, you got to start treatment because you are developing new cytopenias from your CLL. Another common reason that we will treat our CLL patients, and actually often more our SLL patients, our small lymphocytic lymphoma patients, is when they have developed bulky lymphadenopathy that is either causing them significant discomfort or impacting organ function. So for instance, if someone has a lot of bulky lymph nodes in the abdomen, sometimes they can press up on the kidneys and ureters and cause hydronephrosis. Sometimes when the spleen is incredibly enlarged, it can contribute to early satiety and weight loss. So when we see symptoms like that start to happen, then we may initiate treatment for their disease as well. And then there are a few other sort of less common indications, but we do still see them. So for instance, patients with CLL are more prone to autoimmune disorders because of the underlying dysfunction that the CLL causes. So most commonly, we can see autoimmune cytopenias. So autoimmune hemolytic anemia, ITP. So if those occur for the first time, we can typically treat them with steroids, a course of steroids that we can then taper off. But for some patients with CLL, the steroids alone do not work. We may try adding a monoclonal antibody to help as well, but that may still not work. And in those instances that patients have refractory autoimmune cytopenias or quickly relapsed autoimmune cytopenias, then ultimately we feel like in order to treat those successfully, we need to treat the underlying CLL to resolve the immune dysfunction that it's causing. So that could be another less common reason we would treat. And then one common thing that patients always are asking about is how symptoms related to CLL play a role. So some of these symptoms tend to be vague, such as your B symptoms, your night sweats, unexplained weight loss, fatigue. So I always tell patients that usually we will not treat for these symptoms alone. When these symptoms are clearly caused by the CLL, there are usually other indications that would warrant CLL treatment. So they're having progressive fatigue because they're more anemic because their red cells are going down, or their night sweats are really bad because their total white count is 400,000 and they have these really big bulky lymph nodes. So in those cases, the symptoms are there, but we also see the other indications. If someone has really low volume disease and is having those other symptoms, then we often will encourage them to get those worked up for other causes because it would be unlikely that the CLL specifically may be causing that alone.